Mantra, we can start.
Okay. So, a very good evening to you all, and welcome to our next topic of discussion on in the Oncology Academic Forum. Our today's topic is brainstem gliomas. We have with ourselves Dr. Ritika Harjani Hinduja, Associate Consultant, Department of Radiation Oncology, PD Hinduja National Hospital and Research Center, Mumbai. Ma'am, thank you so much for giving us this opportunity. Over to you, ma'am.
Okay. Hello, good evening, everybody. I'll just start sharing my screen. Is my screen visible?
Your screen is visible.
Okay. Hello, everyone. Thank you, Dr. Antra, for having me over. I'm Dr. Ritika Harjani Hinduja from Hinduja Hospital, and I'm talking about brainstem gliomas today. To begin with, brainstem gliomas are, of course, gliomas arising from the brainstem, and that includes midbrain, pons, and medulla oblongata, as the picture also shows it. So they account for about 10 to 20% of all tumors in children. They are actually more common in children than in adults. And median age, we would say, is 5 to 9 years, although the most common would be 6 to 8 years, the central part of it. So brainstem gliomas, whenever you come across this topic, you should in your mind divide these tumors into two parts. One is the kind of benign ones and one is the kind of bad ones. So 80% on the left hand side, we have the tumors, which are 80% of them are in the pons, and these are the ones which are bad ones, and they are generally called as diffuse intrinsic pontine gliomas. They are generally very high grade tumors, grade 3 or grade 4, very locally infiltrative. They generally have their focus of origin in the pons and they go on to go into the midbrain or medulla, sometimes into the fourth ventricle or through the cerebellar peduncles into the cerebellum. So they are generally at the time of diagnosis very locally infiltrative and they have a very poor prognosis. We'll see that. And the remaining 20% of the tumors commonly arise in the remaining part of brainstem, that is the midbrain, medulla, and cervicomedullary junction. They, on the contrary, are exactly opposite. So they are not diffuse, they are focal. They are cystic or sometimes exophytic lesions. They are discrete, well circumscribed tumors, often without any evidence of locally invasive growth. They are generally very clinically discrete. They are low-grade astrocytomas, mostly grade 1 pilocytic astrocytomas. There may be some which may be high-grade and behave like pontine tumors. So we will talk about. So there will be 10% which could behave high-grade. So next would be, sorry. So these are the common locations. The midbrain ones, the A and B, are generally midbrain gliomas. These are the focal ones. This is how they look. And this C and D are again focal ones. These are generally discrete tumors. This D has an exophytic component growing into the fourth ventricle. And E is a diffuse tumor, and which is what we call as diffuse intrinsic pontine glioma. And F and G are again the medullary and cervicomedullary tumors arising in the lower part of the brainstem, again focal tumors. This is just a pictorial representation of their locations and how these are small and well defined versus the E or the pons one is the diffusely growing tumor almost occupying the entire pons. So coming to DIPG, which is the more common type, they are highly infiltrative, most commonly occurring in pons. 95% of them are astrocytomas. They are high grade, grade 3 or 4 generally when biopsied. One poor thing about pontine tumors is even if you biopsy them and you find a low grade tumor, they generally do bad. They don't behave like low grade tumors in the rest of the brain. So they behave aggressively even if it's a low grade tumor in the pons. And recently, with more and more advances in the stereotactic biopsy, and because the dismal outcomes of kids suffering with pontine gliomas, more and more molecular characterization of that biopsy samples has been done. So some mutations are commonly found, which is now the talk of medical research in glioma. So what is the molecular pathogenesis that we see? For the students, I think most of you here are students. So one important thing to remember about pontine gliomas is mutations in the histones. So just to remind you all what this histone is. So in our body, in the DNA, there are nucleosomes. You would remember, there is an octamer of histones. So there are four types of histones: H3, H4, H2A, and H2B, and two copies of each. So these octamer of histones is generally bound by the DNA, and this together unit is called as a nucleosome. So this H3 variant of histone again has two types, H3.1 and H3.3. So there is mutation in one of the genes encoding these histones, either H3.1 and H3.3, and there are names to these genes, like I have mentioned, H3F3A and histone 3H1B. So these mutations are nearly found in 80% of diffuse intrinsic pontine gliomas. What happens is, in the H3, either zero point 0.1 or zero point 0.3, lysine in the 27th amino acid position is replaced by methionine. So this is a very important thing to know for any new practicing person, because this is where all the research is going on in the field of brainstem gliomas, and this is what is even recognized by WHO 2016 now as a distinct identity, that H3K27 mutant uh, diffuse midline glioma, right? And the other mutations, coming to this yellow box here, there are other mutations not that famous yet, or there are not many molecules targeting them yet, but they have been recently found, like the activin A receptor, or which is found in one third of pediatric DIPGs, commonly found with the H3.1 gene. And other than that, TP53, PDGFR alpha, and c-Met proteins are also found. One thing again, the lower right box shows is important to know. So IDH1 and 2, which we talk about a lot in non-brainstem gliomas or adult gliomas, are characteristically absent in pediatric gliomas, or sorry, pediatric diffuse intrinsic pontine gliomas particularly. And by contrast, these non R132H, normally the IDH mutations commonly is R132H, are detected, may be present in some adult brainstem gliomas. So commonly absent in pediatric brainstem gliomas. So this is how this histone looks, the nucleosome looks like. This is there are 8 histones, octamer of histones generally, and the DNA is bound, and in the H3 histone tail, the lysine is switched or taken over by methionine. Uh, while this is a new identity, it is very important to remember it has very dismal prognosis with this mutation in midline gliomas. And recently they have found that even some brain gliomas in general may have low grade tumors, otherwise WHO grade 1 or 2. If you find a H3K mutation, that person will generally not do so well. So that is again being coming up in the recent era in all brains, all gliomas, even brain gliomas, even if it is a low grade. And I was just going through some case reports. So they say that now it is even found in corpus callosal gliomas and cerebral gliomas, and everywhere presence of this mutation is generally bad. So based on these molecular alterations, they are divided into molecular types. The H3K27M, we have spoken a lot about it. We'll speak a little more. And MYCN and silent type. Not much is generally covered on the other two, but H3K27M is now a newly diagnosed entity. So found in 80%. They are high-grade gliomas. Most of this I have said. So in this, again, H3.1 tend to do better. And overall, if you do H3, if you have a H3 wild type case, then that person will do better than any person with H3K27M mutation. Okay, the NMIC has NMIC mutations, nothing much is generally still studied about it. And the silent one is generally without any mutations or these characteristic signature mutations. So next important thing to know is, how do these patients come to you? So you generally have a kid coming to you with about 50% of the patients come with a classical triad. So basically in the brainstem, we have cranial nerves coming out of the brainstem. We have a cerebellum next to it. And then brainstem is, after all, the connection between spinal cord and the cerebrum. So we have all our long tracks going through it. So one of them, or more or less some defect in all of the three pathways is generally seen. This is a classical triad of cranial nerve palsies. We are dealing with pontine gliomas. So sixth and seventh nerve are the most commonly affected. Commonly facial asymmetry or diplopia. Cerebellar signs like ataxia, dysmetria, and long track signs like hemiparesis, upgoing Babinski. So this is the classical triad is seen in about 50% of the patients. The others may have isolated symptoms. Hydrocephalus and diffuse intrinsic pontine gliomas is not that common unless you have a really end stage patient where it has, breached the pons, gone into the cerebellum, into the fourth ventricle. That is when we see it. And cervicomedullary tumors may then see generally lower cranial nerves like the 9, 10, 11, 12 defects. So generally based on these, you can judge the location, but of course MRI is the final thing. Another important thing in the symptomatology is duration. If you have these symptoms, but of a duration of a 1 year history of vague hemiparesis, mild, and then it progressed, it would generally point to a very benign thing or a focal glioma. Duration characteristically is less than 3 months. A kid has a problem, and within 3 months, it is so bad that he has to be, investigated and reaches the diagnosis generally. So uh, these symptoms that I mentioned of short duration, along with MRI, we do not even need the biopsy then to prove the diagnosis of a diffuse intrinsic pontine glioma. Any brainstem glioma, if you have a long-standing history, you can be rest assured that this patient will generally do well than a shorter history patient. Coming to imaging, any CNS tumor, I would say MRI is the modality of choice. CT is not the best for seeing the brain. And they generally see, I'll show you images, but they generally show T1 hypointensity, ill-defined margins, and hyperintense on T2. Another thing is they are generally not very contrast enhancing. So if there is a contrast enhancement, you can think that it is atypical and maybe you should biopsy before labeling it as DIPG. And I'll come back to that slide. So this is how it looks generally. This is the sagittal view of a T1 contrast MRI, and centered in the pons, there is not very defined margins at all, and there are defined margins at some ends. And generally, they are centered in pons, occupy greater than 50% of the pontine width, and generally the basilar artery which is there is engulfed by it. So that is what this says. Tumor core is centered in pons, occupy 50% of its diameter, and engulfing the artery. Generally, they do not have any exophytic components from the pons. This is typically what I mentioned already. So this is the T2 image, hyper intense, and the same pontine tumor. So tissue diagnosis. As I mentioned, this symptomatology with a short duration, with a person with a characteristic MRI, you would generally not do a biopsy given the eloquent or the important area of brain it is, and we would not want to really tamper with it and take any risk. But recently, with the advances in neurosurgery and the type of stereotactic biopsies they are doing, it is more and more encouraged, because then you get to know about the molecular characteristics of the tumor. It may help in some molecular therapy, maybe not yet in the future, but at least it promotes some further basic research so that we can have some molecular therapy in the future. So if you do a biopsy, then you do all the markers that we do for any gliomas, like the glial fibrillary acid protein or the ATRX, P53, even IDH, Ki67, and then we test for antibodies for H3K27M, even BRAF and IDH, and you may do it by IHC or by gene sequencing the H3 mutations. So typically, a biopsy report of a diffuse midline glioma would be something like this. It's an example of a report. So diffuse midline malignant glioma. This is H3K27M wild type, so which is good. WHO grade 3, so better than grade 4, but they all do bad. IDH wild, P53 mutated, ATR. So you get a overall the entire picture of the molecular picture of the tumor, and that promotes some form of therapy that you can use in future. So coming to the treatment is so any cancer treatment, we discuss treatment in three parts. So it is surgery, radiation, and chemotherapy. Apart from, I will come to all of that, but a very important thing is we generally start the patient with corticosteroids to decrease some peritumoral edema, and that really leads to resolution of some symptoms with the resolution of edema. And generally, if after a clinical diagnosis, after imaging, we give steroids, we may not do a biopsy, and more or less DIPGs are treated with radiation therapy. So the surgery is generally not recommended. It is very difficult for a neuro to expect a neurosurgeon to go in there, completely remove the tumor and have the patient without morbidity. It is a very essential area of the brain which cannot be tampered with. So at best, if a neurosurgeon tries a surgery, it will be only a subtotal resection, and then there are reviews and studies which shows that if there is a subtotal resection, then there is no difference in the overall survival. It was 11.2 months versus 11.5 months, so it's more or less the same. And it is such an important area that even biopsy would not be mandatory, may be done just by an experienced team for molecular characterization, but nothing more. Radiation therapy is the standard of care. It is important to know how to treat them with radiation. So there was a review recently in ADRO, Advances in Radiation Oncology 2019, which talked of role of radiation therapy in the management of diffuse intrinsic pontine gliomas. Now, to be honest, I am no expert of DIPGs. DIPG is not a common tumor for anyone to be seeing it every day and every month. So this is an important study because it has used 49 studies and 1286 patients, which is a very huge number of for any study to have patients of brainstem gliomas, and particularly DIPG. So it's a good study, although with a lot of flaws because not most studies are not balanced for comparison with each other. But they have used 49 studies with upfront conventionally fractionated RT, 5 studies with 92 patients using hypofractionated RT, 8 studies with 348 patients using hyperfractionated RT, and some of them with even dose escalation. So what some of the main conclusions were. I've not gone into the details. Most commonly practiced amongst maximum studies was conventional fractionation. That's what we do at our center. Other modalities attempted possibly to improve the distal outcomes, but there has been no real benefit of hyperfractionated or dose escalation with hyperfractionation or hypofractionated radiation therapy. Now, hypofractionated radiation therapy did gain some interest among the radiation oncologists for the reason that if we know that there is a poor prognosis, then why call the bacha for call the kid for prolonged periods, give us 6 weeks of treatment? Rather, let's finish it early. But some studies did show some increased toxicity, and that then stopped people from recommending hypofractionated radiation therapy as a routine. So conventional fractionation is what we use and what is most commonly done. So commonly, what literature says is 54 to 59.4 gray radiation is given. I would say at our center, we generally, given that it's brainstem, restricted to 54 in our cases. Positioning wise, I don't think anyone would have any doubt how it would be, but I would just recapitulate. So it would be a supine position. You would make a 3-clamp head mask. CT MRI fusion will be done, which we do for all our brain tumor patients. And there has been a dispute over what margin expansion, because in gliomas we are used to giving a 2 centimeters beyond T1C and T2 to 2 centimeters, and then give additional PTV for the peritumoral edema and the potential tumor cells in that area. But here, because it is localized to brainstem, and generally it doesn't, if it is an extension to cerebellum and other areas, we definitely give that 2 centimeters expansion in that area. But otherwise, we give a zero point 0.5 to 1 centimeter CTV, about a centimeter CTV, I would say zero point 0.5 is a little too low, and PTV as per the institution. So there was this study. There are not many. If you go through, sorry. So if you go through all these NRG guidelines or RTOG guidelines for contouring gliomas, you would never come across them talking about a pontine glioma or a brainstem glioma. It is generally talking of a cerebral glioma, which is a typical presentation of the glioma. So this is a study from Red Journal last year, 2020, where defining optimal target volumes of conformal radiation therapy for diffuse intrinsic pontine gliomas, published in online in 2019. So what they did was they contoured the GTV, and this is one of the images from there. So they contoured the GTV and had a 1 centimeter margin and then trimmed from barriers, which we would do for all our cases. So, and on the other hand, I don't have that picture now, but they had tumors where they gave it 2 to 3 centimeters margin and then trimmed from margin. So, typically, you would say a lot of expansion going into the cerebellum and other areas, even a little superiorly. And they found that they then defined the pattern. So, about 60 patients with 1 centimeter margin, this was from their study, and around 60 patients or 48 patients, if I'm not wrong, with a 2 to 3 centimeters margin. So they found and they divided the recurrences. So central was like 95% of the recurrent volume as actually received 95% of the prescription dose, and infield was 80% of the recurrent volume had received 95% prescription dose. So they found that majority of these recurrences were only central. There were hardly any marginal recurrences. If not central, they were infield. So then, based on that, and based on otherwise also the pattern of spreading across other studies, it was the margins are generally not very broad as we do for other gliomas. This is one of the other patients where it was just a very small margin taken around the. This is not the MRI picture, but the location tells you about it. So dose constraints, again, I have taken these from the RTOG 0825, where they have even gone to the brainstem point max of 60 gray. But I would say in our center, we give 54 to 56 gray, and we restrict brainstem 1 cc to 54 gray. So generally it's less than 54 gray that we give, or maximum, the 54 gray we would go up to. And the optic chiasm, optic nerve, retina, lens constraints, they are generally common to all brain tumors. So there's nothing new. Here it's point max 55, you would be using 54. So all that is correct. So that's about radiation therapy, the primary therapy for brainstem gliomas. In terms of chemotherapy, the most commonly used, or I would say I have also used for some patients, but it is not with 100% evidence based. It's so if you look at evidence, temozolomide also doesn't have a proven benefit, should not may not be used, but generally the medical oncologists and radiation oncologists are comfortable using it as a radiosensitizer. So in that same systemic review, patients with a radiosensitizer, in terms of any radiosensitizer, any chemotherapy or a sensitizer, may it be alkylating agent or any vincristine or anything. So there was a marginal benefit over no radiosensitizer, but the studies were so varied that there were no meaningful inferences that if you use this particular drug, it is better. Although the most commonly used was any alkylating agent, and temozolomide is also an alkylating agent. So it is more of a gray area even today. So what this is what is basically expected of anybody to know of diffuse intrinsic pontine gliomas. But as young radiation oncologists, I'm sure you should know more about molecular research, because as we move forward, we are moving more towards molecular therapy combined with radiation therapy. That is where our future is, probably immunotherapy and radiation therapy combined. So it is important to know a little bit about these. I've not gone into detail, but as we discussed that at molecular level, this K27M mutation is there in 80% glioma. So that actually causes a negative effect on a complex called polycomb repressive complex, and which, because of which H3K27 methylations are reduced. So that has led to early research that it could be used as a viable target. There are common targets trying to inhibit these demethylases, or even tamper with this polycomb repressive complex, and it has been showing results. So although not been used in, we have not used anything like that, and I don't think that is anything of it is in practice anywhere, but it is, there is a lot of excitement about it. So even they say that these H3K27 mutant tumors are show a lot of histone acetylation. So histone deacetylases, or targeting the acetylation is also being tried. And then CAR T cell therapy, wherein the altering the immune system by removing your own T cells and making them more active against a certain antigen. So using GD2 or a ganglioside, CAR T cell therapy is also being tried. So a lot of things are happening. There's one more drug called ONC201, very initially in the trial pathways, but showing much good response with the recurrent H3K27 mutant gliomas. So overall prognosis, given the therapy that we are using today without these molecular targets, I would say the response to radiation, generally once you finish radiation, the response is quite dramatic. You feel happy seeing, but unfortunately, it is generally a very transient response, and patients are not cured by this approach. So this is one thing which as a good doctor, you have to instill in the minds of the parents that this is the best that we can do, but it is not curative after all. This is not a curative treatment, right? And the median survival, unfortunately, is just 10 months, and 2-year overall survival rate is less than 10%. Coming to some prognostic factors, so age is a prognostic factor. As much as I said that 5 to 9 years is the common age, there are some people or adults with brainstem gliomas. They do not good, I would say. Any glioma, brain glioma grade, high grade is not good, but they do better than the children counterpart. And generally, very young adults, very young children, less than 3 years, or infants with a diffuse intrinsic pontine glioma do better than older children. Other things are, if you have a prolonged symptom duration, you have lack of any nerve palsies, atypical MRI features, contrast enhancement, and these tumors are associated with neurofibromatosis. So if it is attached to associated with a neurofibromatosis patient, then they generally do fairly better than the other counterpart. Coming to their failure pattern, so then generally local. That same study we mentioned about from IJROBP showed that maximum was central or in-field. So that is where they fail. And generally at the moment in clinical practice, approved treatments, we do not have any molecular targets yet, or we are at least we have not used. So salvage re-RT is can be done. I wouldn't say that we have done yet, but there are that same meta-analysis shows that there were 4 studies of 64 patients with DIPG, and the mean overall survival from initial diagnosis was 16 months, and after re-RT it was 6 months. So if you after a recurrence, whether progression to death was 92 days if not re-irradiated, and 218 days if re-irradiated. So there is a difference of about 100 days or 120 days. So at best 4 months probably we are adding to life. But it is very important to know that pontine necrosis can happen, associated neurocognitive sequelae can happen, and even death can happen, I would say. That study mentions that it is better if the interval between the two courses of RT is more, and they have done at a minimum of 3 months between the two courses. I would admit I will never do it at 3 months. Probably not that bold enough, but and I have not come across anybody doing at 3 months, but that's what the study mentions. What doses they gave was 21.6 to 36 gray range, and majority they re-irradiated focal, which makes sense because that is where the tumor is and it's not a disseminated. Though some centers also used whole brain RT at recurrence. Coming to the other part, the focal glioma. So all except this bad looking tumor in the pons, the E, everything else is focal gliomas, fairly has good prognosis. They are discrete, well circumscribed tumors, typically arise in midbrain and medulla, and they are often low grade tumors, so pilocytic or grade 1, grade 2 gliomas, or even gangliogliomas. 80% of them outside the pons, you can comfortably say, would be low grade. Generally, mutations tested apart from GFAP and all those things, IDH is also tested, and low-grade gliomas in the brainstem are commonly associated with BRAF mutations, duplications or V600E mutations. So typically, presentation-wise, they are different in the sense that they have generally isolated symptoms of longer duration, sometimes even up to a year. And depending on where the tumor is, the location would be slightly different. So focal midbrain tumors and that's not medulla, sorry, tectal tumors, you would have a long history of localizing findings, or that is medulla also, it is correct. So isolated CNS, cranial nerve defect or hemiparesis. Exophytic tumors of tectum you would have. So tectum is this uh, the rostral part of the midbrain, and that generally leads to hydrocephalus and associated symptoms because of the this occlusion it can cause on the aqueduct. So uh, generally would present with hydrocephalus and then symptoms of raised intracranial tension. Medullary tumors, you would generally have low CNS defects, low CN defects, cranial nerve defects, apnea, nasal speech related to 10th, 11th, 12th nerves. And cervicomedullary tumors will have generally the tract symptoms, so hemiparesis, quadriparesis. On MRI, we would see a limited size tumor, generally cystic, well demarcated, non infiltrating. They are typically hypointense on T1 and hyperintense on T2, similar to what it was. What it would be, but a discrete tumor and generally contrast enhancing tumors. I don't have a very good picture, but this is how a contrast enhancing brainstem tumor would look like. And we do one more imaging commonly here because we do intend to do surgery here with in advances in neurosurgery. So tractography or diffusion tensor imaging we see so that we can see which tracts are involved and is it safe to resect it completely. So treatment, although there are no randomized trials to support it, but resection is more commonly done for focal brainstem gliomas if it is surgically accessible. And if not accessible, stereotactic biopsy. If not that, then again, biopsy is not mandatory for diagnosis here also. And when surgery is not, generally when surgery is done, there is not much of post-op RT given for all cases or something like that. We may delay it. And when surgically inaccessible, we treat with RTV at a center do 54 grain conventional fractionation, similar to what we would do. We do localized RT, and hence, as much as no one would recommend doing proton therapy or very fancy therapies for diffuse intrinsic pontine gliomas, given the dismal prognosis, these patients tend to do good. So the protons is a good idea. Using very conformal techniques like VMAT is good. So you should use newer techniques. And in some very young patients, even carboplatin, vincristine or carboplatin alone based therapy is attempted to avoid radiation. That has also been done. Special consideration, sometimes when these tumors are causing hydrocephalus, we would need a VP shunt or a ventriculostomy. And dorsal exophytic tumors, generally surgical resection done. Medullary tumors, you generally don't touch the medulla, and then cervicomedullary, you generally treat like the spinal cord. I think that's about it. Thank you. Any questions? I would be happy to take.
Yes, ma'am, we have a few questions related to temozolomide and SRS. The first question is the role of MGMT test and temozolomide also in the adjuvant setting.
Uh, so role of temozolomide and MGMT. I would say that MGMT at our center we would do MGMT testing, but tumors all across studies, if you say the meta-analysis or any other focal study like a individual study, there is no benefit and evidence doesn't promote use of temozolomide in adjuvant setting also. In concurrent setting with RT, definitely.
Okay, so ma'am, next question is the role of SRS in pontine gliomas.
So I think in the end I mentioned I would not think that SRS would do any good to the pontine glioma patient, but a focal glioma, there are some studies. Although we do still VMAT and do a focal RT, but not very stereotactic. I have no experience of doing an SRS in glioma, any glioma, I would say, and I would not recommend it. But definitely not pontine gliomas. There is no role in pontine gliomas.
Yes, ma'am. And you already answered this question on how to treat the recurrent pontine gliomas.
Yes.
And one more question is, do we give temozolomide to adult patient? And if so, after what is the age criteria for such patients?
To be honest, as much as I am telling that there is no role of temozolomide, we have given temozolomide to kids also. There was a discussion in our MDT tumor board, and what we thought is temozolomide is not doing any harm, and with the amount of benefit it is causing in adults. Uh, uh, the medical oncologists in our hospital at Hinduja and all of us were very convinced internally to use it. So that's why I said I have used temozolomide, but it is not, there is no age criteria or anything. Generally, brainstem gliomas, there is no benefit of temozolomide. Adults, there may be some, but generally, all brainstem gliomas, there is no evidence base for temozolomide. We have used it honestly and using the same doses, 75 milligram per meter square. So there is no age cutoff. If you look at evidence, don't use it.
Yes, ma'am. Next question is, ma'am, can we treat by RT wherever indicated all brainstem tumors without a biopsy confirmed diagnosis?
You are legally not wrong to do it. This is one of those few indications where you can give radiation uh, to all brainstem tumors without biopsy. Generally, your MRI report will point you towards wanting a biopsy, wherein if it is a very atypical looking tumor, doesn't look like that pontine tumor, and if it's a dorsal exophytic tumor, and you suspect a low grade and it is surgically amenable, then it would not be a correct practice to do it, but no one will hold it against you for doing it.
Next question is, ma'am, would you prefer adjuvant RT in focal or exophytic brainstem gliomas post-op? And if yes, up to what dose?
So honestly, as much as evidence says surgery, I have not come across any patient of brainstem glioma having had anything beyond a stereotactic biopsy. Either they come to us without biopsy diagnosis or stereotactic biopsy, and we give them a dose of 54 gray. But if it really comes in the post-op setting, I think an MDT discussion I would personally be inclined towards giving, but an MDT discussion would be good. And then it depends on the age. If the kid is very small, 3 years, and if the pathology is really grade 1, then I would not. And then if the pathology is grade 2, there is some residual. So it's a case-based thing based on residual age, histology, the grade of tumor, all those things would be considered.
Okay, okay. Thank you so much, ma'am. Thank you for your valuable time.
Thank you.
Thank you.
I can stop sharing, right, and log in.
Yes, ma'am.
Okay. Okay. Thank you,
Okay.
Antara.
Thank you so
Bye.
much. Thank you.